We move on to our next session, ladies and gentlemen. It's Beyond the Obvious Role of Active Vitamin B12 by Dr. Srinivas is Director Clinical Lab Services, Transplantation Immunology and Molecular Laboratory, MIOT Hospitals, Chennai. He has won many awards, including Young Scientist Award from IAPM, Best Teacher Award from MMM, Chennai, and also Best Teacher and Examiner from MEHE Manipal, Anna University of Madras. He has been honored with Young Scientist Award from ISLH 2011 for outstanding work in malaria. He has 18 international and 10 national publications and also has won many awards as excellent teacher for guiding and mentoring students and residents in clinical practice of lab medicine, immunology, and total quality management. Ladies and gentlemen, please put your hands together for Dr. C.N. Srinivas. And to felicitate him, may I please invite on stage Dr. Praveen Gadkari. May I request you to kindly give them a round of applause, ladies and gentlemen. Dr. C.N. Srinivas. We're talking beyond the obvious role of active vitamin B12. All yours, doctor.
So good afternoon. So we'll just shift from the heart to the vitamin B12, which may not have much importance to some of the people, but it's quite interesting to know that we have a lot of people in our population who are vitamin B12 deficient. So the next 25 minutes to 30 minutes, we'll go around the vitamin B12 and see how it can help to bring about some changes in our healthcare facility. Just to bring about something to our notice, this is a case, 55-year-old female who got admitted to medical ICU with disorientation since 3 days, had a diagnostic workup and the result showed this. Her histogram clearly shows that she has something to do with increased MCV. The MCV was around 133. And this was amazingly having a thrombocytopenia and a mild leukopenia. So you have something to do with pancytopenia with an increase of MCV of more than 110. So friends, we all know that whenever we have a pancytopenia with an MCV of more than 105, most of the time it is megaloblastic anemia. So very clear, had the smears which shows that you have a thrombocytopenia, anemia, macrovalocytes, and you have got a thrombocytopenia in this, and it fits into that of macrocytic anemia. So let us see the classical test which we do. We have a total vitamin B12 which is low, have a serum folate which is normal, LDH is mildly elevated, reticulocyte is high because of this erythropoiesis. So this is a very clear case. So it's obvious that we have a vitamin B12 deficiency and we have a megaloblastic anemia. Now let us see the next case, who is 33 years, who came to medical OPD with numbness and tingling in both the extremities, non-diabetic, had an index of suspicion of vitamin B12, CBC, vitamin B12, folate were requested as a part. So there was no obvious abnormality there. So let us see his CBC. CBC is bilkul normal. Vitamin B12 total, again it is normal, folate is normal, LDH is normal, retic is also normal. Now, should we go beyond this and check to prove that it may not be a vitamin B12 deficiency or it may be a deficiency? So as a laboratorian, have I missed anything, or should I look beyond the clearness of what we have got? So we have to hunt what are the facts behind the vitamin B12 itself, and hence we'll just see about the basics of the vitamin B12. We'll come back to this case after we learn about it. So vitamin B12 we all know is a simple vitamin available in most of the cases in the non-vegetarian diet, whereas the vegetarian diet is usually having a depletion of vitamin B12 because he may not be consuming much of the animal products itself. The main way of getting the vitamin B12 absorption is by a factor called intrinsic factor, which is a protein secreted in the stomach. So this is a simple diagram to show that the dietary vitamin B12, which is cobalamin, enters into the stomach with the help of the intrinsic factor in the stomach and with the acidity provided with the stomach gastric juices. You have the complex of the intrinsic factor and the vitamin B12. They shift to the ileum and they get absorbed over there. So once it is absorbed, it circulates in the blood in two forms. You have what is called as active vitamin B12, which is only 20% of the circulatory complex, whereas you have a biologically inert vitamin B12, which is about 80%. If you take a total vitamin B12 assay, it is going to evaluate in total the active vitamin B12 and biologically inert. It's like our free TSH, free T4 and total T4. It's like that. So if you're going to do a total T4, you're going to get both. So if you do a total vitamin B12, the values you obtain will be from these two components, the biologically inert ones and the biologically active ones. Why do we require vitamin B12? We all know that by the pathways of the homocysteine and the methyl malonylic pathway, it helps us to get a lot of neurological strength and also helps in myelination, progression of the DNA maturation and progression of the cells. So the hidden facts, we found out that it is important that we should have an intrinsic factor. We have active vitamin B12 20%, inactive about 80%, and if you have a total vitamin B12 assay kits, it's going to evaluate both the biologically inert and the biologically active component. So digging deep into this, now when you are having a megaloblastic anemia, that means to say that hematological manifestation of the MCV, that's actually the last stage what you're picking up. So you have 5 stages of the conversion or progression of the vitamin B12 depletions itself. So most of the cases we find out and pick up at this stage, the stage 5 or the stage 4, where you have gotten elevated MCV values. But our concern should be to pick up the early deficiencies. The one is the normal ones and the vitamin B12 deficiencies. Friends, I tell you from my experience of about 840 samples which we did a study, we found out that 25% of our youngsters between the age of 21 to that of 30 have got vitamin B12 depletions because their diet is entirely different. And most of them are pre-employment checks. And it was amazing to see that the hemoglobins are normal, MCV is normal, platelets are normal, everything is normal. But when you check up with the active vitamin B12, it's less. So who is at a risk? I have to put this now first saying that youngsters who are having diet which are poor with that of the vitamin B12 itself. Next, the vegetarians and the vegans are also having the insufficient intake. And more so when you talk about the age group. The geriatric age group is at risk, as well as that of the children who hate to eat the vegetarian stuff or the non-vegetarian stuff. Now other causes are when you have got a pernicious anemia, which is again an autoimmune disease. Then you have got diseases which are going for gastric surgery. You would have seen a lot of advertisements about the bariatric surgeries. So these are the group which also may have a risk of developing active vitamin B12 itself. People who are on long-term therapy with the proton pump inhibitors again are at a risk of developing the vitamin B12 deficiencies. Now why we are talking about vitamin B12 deficiency? Basically these people have got lack of concentration. They have got a decrease in reflex. They have something on numbness, tingling, vague muscle pain, which are not being detected properly. Most of the time we go and say that okay, chalo, we do something on vitamin D because people are saying that vague things are something to do with vitamin D. But vitamin D may be still questionable, the values. But if you really take on a call and do a nutritional evaluation, you will come to know that their diet are deficient in active vitamin B, deficient in vitamin B12, and if you really dig in, they might be having something on deficiency in the active vitamin B12 itself. So now these are the UK USA group, but from my experience we have found out that General population study, we have found out that 4% are having a deficiency. But if you dissect out this 4%, as I told you, the youngster group of about 20 to 30 years of age, when we saw the pre-employment checkup groups, they're having a high incidence of deficiency of active vitamin B12 itself. Now, how to diagnose the vitamin B12 deficiencies? We have got several answers for this. Okay. Now first let us see, now you have got a total serum vitamin B12 assay. Next you have got an active vitamin B12, methyl malonic acid assay, then homocysteine and a complete blood count or a smear study. As I told you, we are all familiar with this, the CBCs and the smear study, and we pick up easily. We say that okay, there is a value of more than 100, you have a pancytopenia, check the bilirubin, mild elevation, LDH is mild elevation, then you can write a remark or advisory note that please evaluate with the total vitamin B12. Still the total vitamin B12 might be normal, but if you check for the active vitamin B12, it might be less. Next, let us check about the value of the methyl malonic acid. The methyl malonic acid is sensitive and specific, but it's very, very difficult to standardize in the routine laboratories. Homocysteine is sensitive, but it's not specific. And mind you that when you are checking for the homocysteine, you have a huge pre-analytical factors, including the diet restrictions, which is not possible. So if you really look, we have left out with total vitamin, we have left out with the total serum active, then you have got a CBC. CBC I already told the drawback of it. So we have left out with only 2 now. So the hematological test can be misleading, which I told you, and the most important is that in India we have got nutritional deficiency of both the kinds. You have a nutritional deficiency of iron as well as nutritional deficiency of vitamin B12 and folic acid. That actually smudges the macrocytic manifestation of the smears itself. So more than 25% of the patients do have neurological manifestations but have a normal MCV, which we have found out for ourselves. Now coming to the total vitamin B12, most important thing for us to know is the pre-analytical error. When we are assaying the total vitamin B12, you should understand that the serum should be wrapped like your bilirubin, because the total vitamin B12 is photosensitive. If you are trying to ship across one reference lab to other reference lab, make sure that it is wrapped properly and you are sending the samples outside, even from the outreach lab to the central lab. That's very, very important. The most important thing for us is that when you talk about the reference ranges for the total vitamin B12, you have an intermediate zone of group between 187 to 220, which are called as indeterminate group. Now, in this indeterminate group, there may be a deficiency of active vitamin B12 itself. So what is the reference range? If you are saying that if it is less than 187, they're totally deficient. We know about it, including the active vitamin B12. But if it is more than 220, we can't vouch or we can't assure that these people are totally deficient in active vitamin B12, because studies have shown that when you have a values of more than 187 and less than 220, still you might be having a deficiency of active vitamin B12 itself. So now we have left out with 2 options. Should I do in my lab the total vitamin B12 or active vitamin B12? So I already told you that if you want to do a total vitamin B12, you should make sure that the pre-analyticals are proper. Announce to everyone that you are doing only a total vitamin B12, because that's very important, and until unless you really tell them that this is a total vitamin B12, they may catch upon you that you never found out that these patients are deficient when you have to correlate with the hematological markers also. Now, active vitamin B12 measures the fraction of active part of the vitamin B12, which is just 20% in our circulating blood. Now, recent studies have shown that the sensitivity and the specificity of this has been improved. So you will be able to have an assurance from yourself that, okay, this guy, though total vitamin B12 is normal, the active vitamin B12 is less, the hematographical picture is normal, but still this guy is an active vitamin B12 deficient. So now you should understand that the active vitamin B12 may be incorporated in your laboratories to make sure that we don't miss the early deficiencies of the vitamin B12 itself. Now, what is our experience with this? Now, I'll just start with few cases and I'll present my study in between. So this is a 24-year-old male, a known case of hypothyroidism, presented with generalized fatigue with a blood sugar of 150 random. Thyroid profile and CBC count was done as a part of workup. So here is a classical case where you have got a pancytopenia, beautifully illustrated, and you have an MCV of 126. So we can assure to ourselves that this is going to be a megaloblastic anemia, because by experience we have found out that if the values are more than 105, most of the time they will be having a deficiency of vitamin B12 itself. So let's study what was his case. Now, when we took the active vitamin B12, it was less than 5 picomoles. Normal for the active vitamin B12 is 25 to 128. So this we are talking about the active vitamin B12. Now let us check with the total serum B12. Yes, it's less. I told you that most of the time the rule is if you have more than 105 MCV, pancytopenia, most of the time your total vitamin B12s are less. In this case, we were able to prove the total vitamin B12 is also less, active vitamin B12 is also less, a clear-cut case or a clear obvious case of a megaloblastic anemia has LDH of 3000, total bilirubin of 2.8 and retic of 3.5. Now let us see what all we did. Now since this was an youngster and a non-vegetarian guy, why did he have a deficiency of vitamin B12? Now when we found out, we did drew the thyroid because he was a known case of hypo. We found out that this guy had hypothyroidism. And when we did the TPO, which was talked in the morning, the TPO was more than 1000. So what does it indicate? You have got now a megaloblastic anemia, hypothyroidism, and this case is also having an autoimmunity of the thyroid. Next, since we have an youngster, we have to rule out antibodies towards the intrinsic factor, parietal cells. Those was done on immunofluorescence. Intrinsic factor was negative, parietal cell was positive. So now the shift is from megaloblastic, macrocytic to pernicious. You have hypothyroidism and what it could be. So when you have got more than one autoimmune disease, one has to think about polyglandular autoimmune syndrome. So what we have done now is that whenever we have a cases of MCV of more than 105, proven that it is a megaloblastic anemia, we further go ahead with the intrinsic factor and advise the clinician to rule out two things, whether he is hypothyroid, and sometimes some of these cases do have rheumatoid arthritis also. So when you look the polyglandular autoimmune syndrome itself, which was described in 2012, you have got various types. You have got type 1, type 2, type 3 and type 4. It is nothing but what we read in our MBBS school. We were told that if you have one autoimmune disease, the person will harbor at least minimum 3 autoimmune disease in his body. So for that, they have grouped into a syndrome called as polyglandular autoimmune syndrome. So we have started a registry of this. Until today, we have got 25 cases of polyglandular autoimmune syndrome. Now, that was a clear, obvious case of vitamin B12 deficiency, where the total vitamin B12 was also less, active vitamin B12 also less, very clear. Now let us see a few more studies. Now you have 25 years male who came from master health checkup, pre-employment. The patient complained of generalized weakness, pricking sensation. CBC folate was requested as a part of diagnostic workup, and let us see the results. Results, CBC is normal. He does not have any nutritional deficiency. Okay. Now let us see what is his total vitamin B12. Okay, let us concentrate on total vitamin B12. Total vitamin B12, 223. Normal. Declared. Serum folate, normal. LDH, normal. Next, reticulocyte, normal. Let us see now active vitamin B12. The active vitamin B12 is less, 16.3. So this is going beyond the clearness, that is beyond the obvious, to pick up cases which are early vitamin B12 deficiencies itself. So this case clearly shows that active vitamin B12 is superior when compared to that of the total vitamin B12 assay. So this was an early stage of vitamin B12 deficiency picked up only by implementing active vitamin B12. So now let us go to the next. You have 58 years male, got admitted with clinical presentation of anemia clinically, has a CBC, serum folate, iron, and everything was done on him because he was found to be anemic. So let us see what he has. He has a microcytes. So you have a flag off of 25, 30, 23, and 29 anemia, microcytic. Okay, he has a microcytic anemia. Not to have a suspicion, but clinically they have suspected a vitamin B12 deficiency, folate deficiency, and iron deficiency. So the requests have come to do all those. So peripheral smear shows severe microcytic hypochromic anemia. So let us see the profiles, what was ordered. This guy has got iron deficiency, very, very clear. So the MCV is low. But look at the other things. Folate, normal. LDH is mildly elevated. And you have got a retic of 3.5%. So next, let us see what is happening to the total active vitamin B12. That is, the total B12 and the active itself. Look at this, staggering vitamin B2, just total vitamin B12 is normal. It's 3 to 3. Whereas when you see an active vitamin B12, it's less. So what does it come to the conclusion? You have overlapping iron deficiency and vitamin B12 deficiency. When you have an overlap and if you are doing a total vitamin B12, still the total vitamin B12 may be normal. But when you look in deeper and dig out and say that I am doing active vitamin B12 and you find out that active vitamin B12 is absent. So you have got a nutritional anemia, which is a combined deficiency of iron and vitamin B12. Now this is our case studies, what we did initially. Initially we were doing it total vitamin B12 itself. We never did the active. We did a study comparing the males and the females. Would like to appreciate only this from this graph. We had about 29 patients, 17% who had a normal vitamin B12 but were deficient in active vitamin B12, provided all the hematological markers were normal. So that means to say that in our population, we have a staggering 8% to 15% of the population who have got active vitamin B12 deficiency. They're not manifesting out with the hematological parameters or something else, and hence we have to adopt to that of resting on the active vitamin B12 itself. So can active vitamin B12 replace the total B12 as a front-line testing? Must be a better marker, so we have to adapt because it's biologically available factor which we are measuring. Must improve offer sensitivity and specificity? Yes, it is more fast superior, easy to standardize and easy to verify in your laboratory as compared to that of the methyl malonic acid or homocysteines itself. No pre-analytical. I told you that vitamin B12 has got a photosensitivity. Do not have a photosensitivity at all. Next, early marker of deficiency, 100%. So it is a very good marker to pick up an early deficiency of the vitamin B12 itself. So how do you approach? You have two strategies. Strategy 1, resolution of the gray zone, which we told. You have 188 to 220 if you have a total vitamin B12. Then you go for the active vitamin B12 if you want. Or you replace completely the total vitamin B12 in your laboratories. You say that for all the clinical purposes, I use only active. I will not do a reflex testing. So what we did, we adopted strategy 2. We totally just removed the total vitamin B12 assays and replaced only with the active vitamin B12 itself. So what is the take back message, what I have to take and go ahead? One is the active vitamin B12 deficiency, or what we call as vitamin B12 deficiency, is significant. Friends, I tell you that it's more important to us rather than our vitamin D is what we are harping upon. And the new guidelines of the US guidelines from the Endocrinology Society in 2015 says that never do an asymptomatic screening for vitamin D deficiencies. So that's been worldwide given now that vitamin D should not be done. But if you really look, a simple test which will cost you less than 500 rupees but gives you an improved concentration, has got good myelination bringing up to the neuronal factors, vitamin B12 should be done in our laboratories. Next, early detection. Yes, we have to switch over to active vitamin B12 rather than the total vitamin B12. The symptoms, the hematological signs are all conflicting. Don't rely upon that totally. The most important is that active vitamin B12 appears to be a promising marker to pick up early deficiencies of vitamin B12. So these were the two articles. One is the laboratory investigation of vitamin B12 deficiencies and vitamin B12 deficiency, which I looked upon. And thanks to Jagannath Sikkan, who shared some of his ideas. Thank you so much.